I'm going to be rushing a little bit and skipping a few slides just out of respect for, we have a lot of presenters and I don't want to cut into their time. And you'll be seeing a lot of numbers and charts and grade tables and all that today. So I'm just going to make mine dialogue and storytelling so you can relax your brains. There's no test at the end. And let's go. We all know that almost every major industry today uses informatics to improve efficiencies and operations. And this is also true with the healthcare industry. The problem is that they're a little bit behind the curve and they need improvement in a few areas. For the second time, I'm only going to cover two of these, and that's standards. And then also, in my opinion, I believe that the healthcare industry is still a little bit too reactive and habit-based rather than knowledge-based and proactive. And I'm going to be talking about that. There's a massive amount of health data that exists right now, and it's increasing exponentially. And it's great having all of these data, but you have so many systems that use proprietary software and they don't communicate with each other. So we can't analyze the big picture, and that's something that's needed. And there's also a lack in some areas of standards. Thankfully, we do have some standards, and that is with the coding systems. We have the ICD-9, ICD-10, and the 10 I've been looking at that for the last few months. It came out in October, and it's really impressive. It's a coding system for diagnosis and procedures, and it's light years beyond the 9, so we're making progress. We also have the HIPPICs, the CPTs, the NDCs, which are other diagnosis procedure codes and drug codes. And so all of this is great. We have the XML formats that help systems communicate with each other, but still, the healthcare system is primitive, it's reactive, and it needs to change. So what does this look like? This is my opinion. I believe that this is a philosophy that's held a little bit in the healthcare industry, that's the way we've always done it, so that's the way we're going to do it. And I'm not saying that there's not advancements, because there are, and there are updated procedures, but as I give you a few stories, you'll see what I'm talking about. I have a friend, this is not too long ago. She had severe pain on her left side, and she had profuse vomiting. She was brought to the hospital, she went into surgery. So what did they do? Because this follows the books and this follows that old reactive policy, they opened up her right side. They said, vomiting, abdominal pain, she must have an appendix problem. They look at her appendix, it's perfectly healthy. What do? They take it out, they sew her back up again. And I asked the surgeon, I said, why did you take out a perfectly healthy appendix? And he said, well, it's one of those evolutionary leftovers, we don't need it anymore, and it's our policy. If we've got them open, we take it out. And they did, the next day they did open up her, again on the left side where the pain was, they found a necrotized ovary and they took it out and they said it. So, and I'm going to get back to that appendix in a minute. But also it seems like you go to the hospital, every time somebody sneezes they want to take out a gallbladder. Or every time a parent brings their child in with a cold or another viral infection like the flu, they start handing out antibiotics like popcorn. And these are kind of reactive ways of living. This is not knowledge-based. So now, let's get a bit of knowledge here. We know now the appendix is a reservoir for bacteria. It repopulates the colon after there's an infection. And these bacteria are critical to a person's health. And in recent years, we've been learning that this massive epidemic of obesity in the country, it's not just a lack of discipline, it's not just people overeating, it's because the preservatives in our food are killing the bacteria, which is changing the way that the bacteria help us to keep healthy, and that's a part of the obesity. So taking out the appendix is a big deal. Then that's a reactive behavior. The gallbladder, we want to take those out all the time, but that portions the flow of bile to aid digestion of the fats. And without the gallbladder, the bile continuously trickles through the liver into the digestive system, causing chronic heartburn, irritable bowel syndrome, and even colon cancer. And also, we all know that the overuse of antibiotics is creating superbugs, which puts us all at risk. Now, the healthcare industry does have some proactive policies, but these aren't always based on knowledge. This, again, is somewhat based on ignorance. Now, let me give you an example, and this is probably controversial, but fluoride in the drinking water. Fluoride has a stronger negative charge than iodine. It displaces the iodine in the thyroid, which is the master controller organ of the body. It disrupts the entire endocrine system. In children, it causes brain damage, lower IQ, and in the elderly, it causes osteoporosis. It also causes kidney damage and other health issues. And I have in the references, you can read the articles. So what do? We need to switch from we're actually having switching from a fee-for-service-based system where the more tests that a physician did or the more procedures that they did, the more they got paid. That's been going away for years. But what we need to use is we need to use healthcare informatics. We need to take massive databases, get them communicating with each other, and then look at populations and patients over time. What it is, you link a procedure, a practice, to an outcome. And doing this, you can start coming up with a new form of healthcare where it's quality-based, it's patient-centric, and it also even looks into the patient satisfaction. I can see I've got 10 seconds left. So what I'm going to say is that talking about patient-centric, and that is where I want to say that information now, with all this massive information available, can be put directly into the hands of the patient. Dude, didn't turn on. What the heck? Okay, that's disruptive. So technology can be used, such as computers and tablets and smartphones, through the development of patient-centric applications. And this is where I'm going to hand it over to Professor Cochran, and he's going to talk about that.
Thank you, Joseph. I wanted to start off with a quick video that I hope will illustrate one of the issues that we face in terms of looking at personalizing patient records. Oh, that's a shame. Okay, well, if you looked at this video, it was a clip. It was a clip of a Seinfeld episode in which Elaine Bennett is sitting in the physician's office, and she has a chance to sneak a look at her patient record. And in the patient record, she sees the term difficult. And she asks the physician about why do you see this, why am I a difficult patient? And he said, oh, I don't know who entered this in here, let's just erase it out of there. And he takes his pencil and he starts erasing. And then she says to him, but it was in ink. You didn't really get rid of it. Part of the issues that we're dealing with patient medical records is that they are very paternalistic. That essentially the patients can't understand the information in their medical records. And by and large, there are a lot of things in their codes, etc., that are going to be difficult for patients to understand. So we need to develop, as Joseph was mentioning, some new technologies that will equate what is going into the patient's chart into a language that patients can understand to help them better understand their medical care. It can also help them to make better informed decisions. If we have a patient health record that the patient has access to, we can see perceived enhanced communication with providers and the healthcare team. It helps them to keep their appointments. It helps them to ask more intelligent questions. It improves coordinating their care between providers, and it gives patients the perception of more control over their care. Some of the disadvantages, though, are inconsistencies in content. So will a patient be able to equate what one physician had said in a medical record with, say, what another clinician may have said? And the disclosure of information can also create stress for the patient, difficult patient. If we were to put all of that information in the patient record, it would be very difficult to get providers to participate. However, if there was a way to bill for difficult, you might want to include that in the patient record. It can also create the risk between the patient and provider, and the potential to create risks between providers. Why did he run this test when he should have run that test? The example that Joseph gave about the appendicitis patient. You know, somebody else looking at that record, if they had a chance to look at that, might have said, you've got a big problem here in how you conduct your business. You need to do a better job on preparing your patients for care. The challenge is making that record into a system that is more readable to the patient and more understandable. One of the things, I'm also, what wasn't mentioned, I'm also a member of the Public Employees Benefits Program Board of Directors, which makes me a very popular person at UNLV because we handle the state of Nevada health insurance benefits. And I'm typically asked about, and when I say popular, I mean that facetiously. I'm typically asked about the type of access that we might be able to get to our patient information, particularly for doing research. Some of the things that we don't do very well with our information, however, is making that information available to our patients so they have a better understanding as to the care that they've received in the past and maybe the types of care that they're going to need going forward. In my early days when I was getting into this field, I remember somebody showing me a card and saying, here's your health information. This is your insurance card. And if you looked at UNLV's insurance card, you see it's just an insurance card with telephone numbers and addresses on it. If you looked at a credit card, you would see a strip on the back of it. And there would be the availability in that strip of having information available. Now we put chips in our cards. And so the question is having a patient medical record that might be portable for the patient and so that they can get access to that care without having to provide the same information to a caregiver over and over. How many times have you ever been to a provider's office where you've had to fill out the same medical history and the same family history? Having that information readily available in some record-keeping system would enhance what is going into your medical record, and we could continue to update that record. Joseph mentioned in the pre-capitated days how we were insulated from our healthcare decisions because we didn't care so much about it because our insurance covered everything. I mentioned in my role now as a board member of PEB, we've seen our deductibles go up under one of our plans to $1,500 for an individual. If you are accessing care and you don't have knowledge about what is associated with that care and the cost associated with that care, you're going to be out a significant portion. So how do we recruit patients to coming into care? Well, one way is we put up billboards around the communities telling us how much of a wait time there is for an emergency room. Yet we know emergency room care is expensive. We also know that it's going to end up costing the patient a lot more, especially if they have a high deductible plan, in terms of gaining access to that care. We have to ask those questions. Who's benefiting? Will they take our insurance? But ultimately, there are there are solutions available that Joseph talked about by creating smart devices that have information available to the patients, by getting access to our patient records in our health systems to understand what providers are in our health systems, where they are located, what the cost is associated with that if you go in-network or out-of-network, so patients can make much more informed decisions about where they're going to go. I know we're running out of time here, and I want to cut it short, and I've got to run away to a meeting after this, but if there are people who are interested in this topic of creating a personalized medical record that's accessible to the patient so that they can make better decisions, I'm happy to talk to you about it. Thank you very much.
Thank you so much, Chris and Joe. It's a topic which inspires a great deal of first commentary amongst people regarding medical informatics. Let's go on to the next.